Welcome everyone to the Avoiding Ambulance Claims Issues webinar. I'm Tom Ryan and I'll be your presenter. Our goal is to look at the data, the actual system data, and to determine what are the issues that we're currently seeing. Today I am joined by Leanne. She's going to be my chat host. Her job is to, again, put links in the chat, look up information for me if I give a call out and say, hey, could you look that up? Or even help you with the answers. Because again, we will only take questions in the chat so that we can control. It's much easier than trying to mute and unmute and go back and forth. Okay. Remember to view the disclaimers. They're at the end of the presentation. And after everything is done, you'll be asked to take a survey, and we'll talk more about that a little bit later. But also you'll be given a variety of different links throughout. So we want to make sure you're aware of kind of what we're going to do. Why are we doing all of this? Well, our objective is to reduce the cost of claims denials, rejections, and not adjudicated claims. Basically, we want to look at the claims and bring that cost down. Someone did ask, and it was a very good question, how does reducing that cost affect the provider? Remember, time is money. So if you're submitting a claim and then you have to research why it's denied, what happened with it, guess what? That's money spent because that's time. Same thing happens with us when we look at data, when we look at the edits and the audits, and are they working correctly? Do we need them still? Are we still, hitting enough of these, and are they valid? That's all time and money. So that's what we're trying to do. Again, reduce the cost, but not only for us, but for you as well. Okay. So in order to do that, I do want to define the data that I use to determine the denials, rejections, return to providers, all of those different things. Because if you don't understand where the data came from, a lot of it's not going to make sense. Okay. I will go through the individual common denials. Now I use the word denials, and I will tell you a denial is just a very generic term. It actually falls into different categories. This could be a technical rejection. This could be something like unprocessable or return to provider. We didn't even pay it. We didn't do anything with it. So I'm going to use the term denials in a very general manner for the most part. If you have questions on that, please feel free to put that in chat. Leanne will help you through understanding that. Other things that are going to happen, I'm going to show you some different resources, which are great to help you out and kind of avoid some of these issues and these things that we're seeing. But some of those use acronyms. If you've never dealt with Medicare, and I do know there are a few of you on that are brand new and are just getting started, and I want to welcome you and say, hey, thanks for joining us. But I also want you to know that I'm going to use acronyms throughout. And I'm going to use acronyms as termed by CMS and by WPS. If you don't know an acronym, please ask Leanne in the chat. Now, on your slide deck, if it's an acronym on the slide, actually in the written information, look to the bottom of it, it'll have a definition for it. So we do want to make sure that you get through all these different pieces of information. And I want to again remind you that we do have some legal disclaimers at the end of the presentation. I really would recommend taking a quick look at those. All right, let's get on with the data explanation. So I want you to understand where the data comes from. This will hopefully answer some of those questions. Why are we looking at it? What is the data and what is the goal? Okay, so first I did pull data, and what I used to pull data was not anything specialty wise. What I did on the other hand is looked at ambulance procedure codes. This then allows me to pull out of both systems, and I'm going to talk about the two systems in just a couple of slides. But know that by using procedure codes, I'm not pulling just from one or the other. It actually pulls from both systems. So we'll talk more about that. What procedure codes did I actually look for? Well, I looked for non-payable procedure codes, but I also looked for the payable procedure codes. And I wanted everyone to be aware of that. And then I said, I'm not really interested in all the claims that paid. That's not going to help me understand the denials and understand what's going on with the denials and what are we doing with that. So I removed the payable codes, the paid codes, the ones that actually processed, and I looked at just the not payable information. So these could be, again, denied, rejected, unprocessable, a variety of other things, and we'll get more into that in just a few moments. So that's where the data came from. And again, it's a system data report. I'll show you that report really quick. It's kind of an interesting report, and it comes in a big export mess, and then I have to sort it. So this is what it looks like, and you can see it defines by line of business. You can see it's got states, counties where I got to go within each state, and a variety of different pieces of information, dollar amounts. Oops, I'm sorry, I forgot to show you the header up here. It shows me the number of providers affected, all of these different things, and then actually gives me the denial code. Then I have to do the manual sorts, which is where all of these come in. These are just manual sorts, nothing super major. So this is what the data actually looks like, and this is the actual data used for this webinar. So I did have a couple people that asked me for that information to kind of see it more than just for me to explain it. So I thought, okay, I'm going to show you, but if you want more information, I'm going to leave it up in the background. And what I would really like you to do is put some questions in the chat. Otherwise, I don't know what else you're looking for with that. All right. So to summarize, this is what we're going to summarize really quick. The data shows that the biggest thing that we want to look at is actually the bottom bullet point here, and it's $73 million, $536,361. These are not covered. Now, again, they're not covered because we denied them, they're unprocessable, they're all these different things. That's a lot of money. When we can contrast that to other specialties or other items, it's not as high as this. Ambulance has one of the highest denials, but doesn't have one of the highest volumes of providers. So the contrast there does significantly speak to that amount. Now, again, I didn't pull ambulance specialty and say just want ambulance claims or I just want rev code 540, 540X, 54X. I didn't do any of that. What I did is said, okay, we're going to use these procedure codes. And that's where the PTAN count comes in, and it tells us the total providers affected, but it also tells us the number of beneficiaries, how many lines, and how many units are not covered. I did not pull by claim. I just said line instead of claim because ambulance runs should be billed on an individual line item, regardless of whether you're billing on a UB04 or a 1500. Okay. So this is what I got for a result, and this is why we're doing it. And again, if you want to circle it, circle that bottom $73 million number. That's a lot of claims for us. It's a lot of denials and a lot of money. So we move on and they say, okay, now what do I do? Well, I have to look at two different systems, and this is where I kept talking about the two different sides of Medicare. CMS uses the Part A and Part B, but they use the line of business. It's not a benefit category. Ambulance is always a Part B benefit category, but it falls under two different lines of business. Part A is a UB04 or an 837I defined by CMS. Those claims are then submitted to the FISS, Physical Intermediary Standard System. Some people will say shared system. Either one is correct. These claims will either be returned to provider, denied, which is medical necessity, or rejected, which is a technical denial. You can't do anything with it. A return to provider means there's something so wrong with it, we can't even process it. We didn't deny it, we didn't reject it, we didn't pay it, we didn't put it to deductible, we just couldn't do anything with it. So essentially broken. Okay. We also use a second system. The second system is called the multi-carrier system, and by CMS definition is the Part B line of business. This is always done on a CMS 1500 claim form or 837P electronic submission. So that's how CMS breaks it up, which is then how we break it up. Okay. So when we look at that, like FISS has the return to provider. Remember, this claim is not adjudicated. We can't do anything with it. We're stuck with it. Same thing with unprocessable. That is the MCS version of return to provider. Okay. Here's the difference. In the FISS system, you can go in and fix it sometimes, and we'll talk about that in a little while. In unprocessable, you can't. You have to submit a new claim. There's no fixing an unprocessable claim. Now, in FISS, there is, and that would be entering direct data entry and actually fixing the claim. Okay. Then you have the term denied. Now, in the FISS system, we have what's also rejected. You guys see the two difference specified right here. These are technical, nothing we can do with them. Maybe it's the law that said, hey, this isn't going to be an appealable. These are more your medical necessity. That's what a denied is. In the MCS system, it's not broken down that way. It's simply a denied claim. So medical necessity, technical, all of it fits into one category. Someone asked about the discrepancies in the dollar amounts. And why does the MCS system have such a high dollar where FISS has so much of a lower dollar amount? Very simple to explain. There are more private suppliers that bill on a CMS 1500 or 837P than there are facility-based ambulance companies that bill on a UB04 or 837I. Therefore, the dollar amount is reflected of how they bill. Okay. So hopefully that helps everybody, gives you a little bit back and forth. Kind of wanted you to have a little bit of that before I got too far into the data. Leon, I do want to just verify that I don't have any questions before I actually start getting more into the data.
Tom, we don't have any questions that have not been answered in the chat.
Perfect, thank you. All right, so let's divide the data a little bit first. I want to start off with the smaller volume data. This is the return to provider data actually in the physical intermediary standard system, FISS. This is the UB04 837I data. So the return to provider is the data that you can go in and fix so long as the tape to tape field indicates this. Now the tape to tape field is a item that you can actually go in and look at in the direct data entry system. What you're looking for is an X in that field. X. If it has an X, you can't fix it. You have to submit a new one. And if it doesn't have an X, then you can actually adjust it within the system. So a couple of things there. Um, but I do want to talk a little bit about what we're seeing with the return to providers. The first one, interestingly enough, says that the provider is not covered. This is definitely a provider enrollment issue. Or not definitely. This is could be a provider enrollment issue, okay? Could also be something as simple as you told us it's not covered. Well, why isn't it covered? The answer is it doesn't meet the medical necessity section and therefore doesn't meet the benefit requirement in the Social Security Act. I'm going to give you guys a number with the Social Security Act. It's section 1861S7. That section is not about medical necessity. That says in order to be covered, the service has to be first a transport, second the only safe means to get the patient there. That's where that comes from. Okay, so for some reason you're telling us, hey, this isn't covered. We know that. Okay. If that's the case, guess what? We're just automatically going to return it to provider. Now, we do have some other edits depending on where it gets hit within the system and whether or not you're including a modifier. Okay, so I want to make that very clear. The next one tells us that there's an origin and destination modifier that's not valid. So what does that mean? On an ambulance claim, and it doesn't matter what type of claim you bill for, you have to put a two-character modifier together. One represents the pickup location and one represents the drop-off location. When we look at those two, we also have to make sure they're valid. An example is the second bullet point on the fixed side. Medicare doesn't recognize a physician's office as a drop-off location for an independently billed ambulance claim. Why? Well, it's in the regulations that it's not a destination. We don't pay for those. So therefore, if you're using a P, it's not going to work. But we could recognize that as a pickup location. So P in field one, or in the first position of the modifier, not the second. If you do have that, there is an X which you could use to say, hey, I got to stop for an emergency. I have to do this. This is an optional. There's some different things that go there. So I want to make sure that you are well aware of that. There's also some other things that hit for not valid modifiers. A lot of people ask about the E's versus the N's, and one is a domiciliary care facility, E. One is a skilled nursing facility, N. And really the difference is Medicare. Did you guys catch that? Medicare paying for the Part A inpatient care. If they are, there we go. Um, Also, I had this question come in and I wasn't really sure what the person's referencing, so I did put it on here, but if you can give me some more information, I might be able to help you better. A facility is using an S as a destination. An S is the scene of an accident, and they're asking if that's a valid destination, and my answer to you is no. Why do you intend to take them to a scene of an accident or a scene of something happening? That's not a valid destination. It definitely could be a valid origin, right? We know that. So if you can give me a little bit more on that, I might be able to answer it a little bit better. I know the edits there. I know it's set up that way, and it does cause it out to RTP because the base question is, why are you taking them to the scene of an accident? Um, so I thought that that was something that I would put out there. Um, let's do this again and move on to the next. This is a section that is a lab service that's billed, and this is part of the laboratory information that CMS has in place. So we have to follow what CMS tells us. What I did is very much on the bottom of this slide, you're going to see the Medicare Claims Processing Manual. You're going to see Chapter 16 Laboratory Services. CMS says that if certain laboratory codes are billed, it doesn't matter what else is billed, which could be an ambulance, could be a variety of other things, we can't process it. We have to return it to the provider. That's where this comes from. So again, that's about $9,000, but it's not a big effect if you notice. It's the same data service as a lab service, so we're saying, oh, no, this can't be done. It's a total of 10 claims. But I wanted you guys to have that information in case someone sees it because it's not an everyday frequent one and they're like, what is going on with this? That's where it came from. Now, the SNF admission is also going to come up again in another set of denials for the FISS system. So I do want to talk about this. This one is a return to provider SNF admission, and it means that they are in a SNF at the data service and there's inpatient care. Again, you want to review the consolidated billing rules for those of you who are not familiar with that. The skilled nursing facility is paid for all care and they must coordinate all other care from outside vendors. Okay, this is what consolidated billing is. They then bill Medicare for things that should be billed, and they are responsible for then paying the outside vendors. Okay, that's the big concept of SNF consolidated billing wrapped up into a couple of sentences. Gets a lot more complex. So, um, what I want you to do though is make sure that this particular information is something that you look at and it's in the skilled nursing facility consolidated billing rules. It's on the CMS website. What you want to do is determine if your ambulance transport is considered bundled into another transport. Another transport. Hopefully that makes sense. Again, I gave you the link right down here on the bottom. If you open it up, oop, that's not opening for me. There we go. Like if you open it up, it'll actually give you a couple of different files, and there's a little bit of confusion. So the top Part B file has four different files, and there is an ambulance file within it, but the Part A file is the one that we want to look at when they're inpatient in a facility and Medicare Part A is paying for the skilled nursing care. That's only 100 benefit days. It's only 100 days. If they are paying, then we use this file. If they're not paying, whether it's they live there, it's a domiciliary facility. They may have both types of beds in that facility. Whether they are beyond the 100 days or there's a technical type of rejection, then we're going to open up this file and follow through with this one. Okay, so this is the MAC Part B. This is again when they are in a facility. It is a medically necessary stay, but Medicare is not paying for whatever reason. Hopefully that kind of helps you understand a little bit. Okay, let's jump back to the PowerPoint here. The next one is not filed timely. Well, this is when the claim must be filed within 1 year from the date of service for an outpatient service. It's the through date on a UB04 or an 837I. You see, it doesn't happen a lot, but you do have to determine whether or not you meet the filing exceptions, and those are given to you in the Medicare Claims Processing Manual, and that's on the bottom. Okay. Now, again, in the bottom of the slide, you'll see a link. You can click it open. You can read through those exceptions and see if they apply. One question we got and we continue to get is, does Medicare secondary payer meet a timely filing exception? And the answer is no. Does not meet a timely filing exception. But again, go ahead and review those pieces of information. So that's it for RTP. Next, we're going to move into the technically rejected claims. Now, in FISS, a technical rejection is something that you cannot appeal. It's not going to give you an appealable denial. It's not anything like that. It is not a medical necessity review. It means as part of the law, something isn't done right. We can't pay this. So there's no additional actions to take on a technical rejection. If you do have a technical rejection and there's some other piece of information that may have helped it pay, you do have to send in a new claim. Not something you can go in and play around with. Now, there are some technical rejections that will allow you to adjust a claim, and you can do that too in direct data entry. So it just depends on what's going on with that. Okay, let's talk a little bit about what's happening. One, charges on a line were submitted as non-covered. So unlike a RTP claim where it was the entire claim that was submitted as non-covered, this one says, hey, just these lines. Why would we do that? Anyone know? Or what if the patient says, I know this is, or you know, because your emergency medical technician or EMT evaluated the patient and said it's not medically necessary, man, they could safely go by a different means, but their physician told them they have to go by ambulance, so now they're insisting on it. Well, that's preference of the physician, right? It's not going to necessarily meet the coverage criteria. So you can append that and put a GY on it. The patient may insist that you bill it to us because then that gives them appeal rights. And while you don't have appeal rights with that, they do. So it just there's a variety of different reasons. Sometimes you actually bill these because you need it for the secondary insurance. So maybe it's Medicaid or maybe there's an insurance that pays after Medicare. That's why you're billing it. And then the other one is just to avoid future denials. So you bill it in case the primary comes back and takes money back, but you know it's not covered and you want the patient to see that in the future. That's why you're doing all of these different things. So these are not necessarily wrong. They're not necessarily things you can't bill. That's not it. It's just we need to look at it, and when we determine doesn't need to be billed, because Medicare says it doesn't need to be billed because you automatically know this is not covered. Okay. Now remember, on this line, you submitted one of two modifiers with this. You submitted the GX or the GY. Why did you submit those? Because the EMT cannot diagnose, so therefore we rely on the modifiers on the line to tell us that it's not medically necessary. Unlike some other types of provider specialties and hospitals and all of that, that they're going to use a diagnosis and that's what we would use. This isn't that case. This is a coverage exclusion. We also see a lot of primary payer and technical denials. And this means hey, we don't even have the information to process it. We see a primary payer on file. We say it's applicable to this um, to this patient for this data service, which the claim doesn't contain the correct information, so we can't do anything with it. So you have to go through and make sure all the information is there for primary payer. Okay. You may also hear this termed as MSP or Medicare secondary payer. Those are common names for it. All right. And basically, if the fields are not completed correctly, we're not going to pay it. There's also something that we call inpatient bundling. Now, inpatient bundling simply means that um, the hospital has an inpatient bill on file. Similar to a skilled nursing facility, remember I talked about consolidated billing, SNF consolidated billing, except this one is for a hospital. So that's the difference. When a patient is in an inpatient hospital stay, we are not able to pay the ambulance claim if it is an acute care hospital. Now, there are some payment methodologies that would allow for this, and that would be like a critical access hospital. But what we're looking at is the revenue code 540 not being allowed on an inpatient claim. Why? Because the ambulance claim is never standalone when they're inpatient. It's not a standalone item. Instead, you're transporting that patient for something. Let's use an MRI as an example. The patient is in your hospital, your MRI is fully booked, but you need to go to the neighboring hospital for the MRI. You're not discharging them, you're just temporarily taking them over there, getting the MRI, and then coming back. That MRI is where those ambulance charges are built because how did they get the MRI if you didn't get them there and bring them back? That's what's happening with this technical denial. Okay. Along with that, the next one is that patients are not, I'm sorry, Medicare is not allowed to pay if they are incarcerated. If they are incarcerated. And so we want to make sure that we're billing it correctly. Now, you say, wait. Understand that it's basically whoever incarcerates them should have the responsibility to pay, except they don't pay that. That local government is telling us they don't pay that. What do I do? That means that you didn't put the modifier on there correctly, and that is the QJ modifier. Okay? So that's the fix for it. Now, if they are incarcerated and they are responsible for paying the incarcerated agency, government is responsible for paying, you should be billing them, not Medicare. You should be billing them. So this is the correct rejection. It's not an appealable rejection because it's not about medical necessity. It's about whether or not you appended the modifier and whether or not they should be paying. The next one goes more into the consolidated billing type information. And so again, it's just this one is the rejected for consolidated billing and it's not payable separately. This is a service that is part of or subject to consolidated billing. And again, it goes back to the same thing that I just talked about with inpatient. In order to get the patient that service, you had to get them there. That's where the ambulance falls into it. Okay. So hopefully that all makes sense. All right, let's move on, and we're going to move to FISS denials next. Now, FISS denials are the medical necessity things, the things that are appealable, some things like that. All right. So let's talk about it, the first one, and the biggest one for this is timely filing. Again, it is about the waiver and whether or not you can file a waiver. I want to remind you that whether it's a technical denial or whether it's a technical reject or a denial, it doesn't matter. The action is the same, and that is to verify that one, there is a timely filing limit, that you do meet the exception process, that you should write to our claims manager. Please don't file an appeal. That is not going to do anything for you. You have to write to the claims manager and you have to make sure you go through all of that. All right. Now, there are some origin and destination modifiers that will cause denials versus strictly not payable. And I gave you an example of an S. This is an origination and destination modifier. That's a technical. Why are you taking them to the scene of an accident? So you want to look at that. Also on a denial may again be the E versus the N. What is the E? What is the N? Okay. Well, let's take a look at that. I did see a question come in and I don't remember the question. So Leanne, I'm not sure what the question was. If you could locate that and maybe help me out while I open up this manual.
Yep, Tom, there were two questions that related to E. One was asking you to go over E versus N, but a secondary question regarding E is a transport from a residence to a hospital, or excuse me, hospice facility payable? We use E as the modifier for the hospice facility, so modifiers are RE. We typically get a denial stating transports to and from this destination are not covered. However, the patient typically is not able to receive hospice services at home in these situations.
Okay. So yeah, we'll take those all together. So here's the general billing guidelines, and what I did is I went into the Medicare claims processing manual. It's on the CMS website. Again, the link was on the bottom. It automatically opened for me. It opened to chapter 15. It's general billing guidelines that I'm looking for section A. Okay. I just searched by origin. It brings me right to what I need. And then it gives me a valid list of origin and destination modifiers. A couple of things to keep in mind. One, these are the modifiers that we can use. As an origin, make it fit. Make it fit. As a destination, if it doesn't fit, it's not a payable transport. Okay. So let's talk about E versus N. Resident domiciliary custodial care. E. N. Skilled nursing facility. A skilled nursing facility is something that is payable underneath that prospective payment system. It's not necessarily a hospice facility. Okay. A hospice facility can be a residential domiciliary or custodial care facility. That's fine, but it's not necessarily a skilled nursing facility. Okay. Now, hospice facilities are going to be a little bit different because they could be a diagnostic or therapeutic site, but it doesn't count as a hospital. And that's what this is going to tell you. It's not a physician's office, it's not a hospital, but it is a therapeutic or diagnostic site. Someone asked, could it be a hospital? And absolutely, it is a part of a hospital, if that makes sense. And so, because it's part of a hospital, it's owned and operated fully by a hospital. It doesn't even have to be on the same campus. It's still part of a hospital. Okay. So, those ones really kind of throw me off when I get those questions because I don't have enough information to really give you the answer. I don't know how they're enrolled. But again, going back to the E versus the N, yes, a patient can have the same facility and be in an N nursing facility. For that facility to be in effect, Part A, Medicare Part A has to be paying the skilled nursing facility charge. Once the 100 days pass, if they remain in a medically necessary stay or a not medically necessary stay, or a stay that doesn't meet the technical requirements, but they're still in the same facility, it moves to an E. Because an E says this is where they are at. It's a resident, domiciliary, or custodial care facility. Again, hopefully I got that correct. Remember, medically necessary and Medicare is paying for the first 100 days and otherwise E. Okay. Um, and I wanted to bring you out here because I saw the questions come in. I just wasn't sure what they were. So let's jump back to the slide deck and hopefully that answers your question. So when we look at it, we're looking for the same thing, whether it's a denial or a rejection or a return to provider. That's what we're really looking for. Now, there are some services that are denied as non-covered, which could hit an RTP, which could hit a technical rejection, but there are some that will also become appealable. Now, some of the services that become appealable for Medicare in the Part A system is if it's medically reviewed, and that does happen from time to time. So I wanted to kind of provide you guys a little bit of the difference. These services that are considered non-covered are the medically appealable ones, may not be necessarily the Medicare Administrative Contractor, which is WPS. May not be our decision. It could be something like a recovery audit contractor, which you could do an appeal on. It could also be something like a comprehensive error rate testing contractor or another federal entity. That's where these ones come in. So hopefully that all makes sense to people. Okay. I will tell you that if you are submitting it as non-covered and then you want us to consider it and you're going to do the appeal, the removal of the GY, GX, or condition code 20 does not mean it's going to be medically reviewed. Instead, we're just going to put it through because now you've told us. So I want to make sure everyone's kind of aware of how that works. The next one is also appealable, and it does come from a medical review. And what it is some staff that are review, whether it's again the MAC, whether it's the CERT, whether it's the RAC, whether it's the Office of Inspector General, whoever did it, and what they actually found is we don't have the documentation, we need to pay that claim. If we're missing documentation, that does give you a right to do an appeal. Okay, so that's what this one stands for. I'm going to go ahead and move on, and we're going to switch systems. Remember, we're going to switch systems. I talked about two systems. We're going to move to the other system, which is the multi-carrier system, which means that you build on a CMS 1500 or a 37P claim. Now, this is the bigger volume of claims. This is a bigger volume. When we look at this system, we do start with the term unprocessable. Just like we started with return to provider, fix it, send in a new claim, same thing with unprocessable. Well, return to provider, sometimes you can go in and actually fix it in the system. You can't do that in Part B. You do have to send in a brand new claim. The system will ignore. It's not going to look at any of these. So we want to make sure you're well aware of some of the issues that are happening here. First, information needed. We asked for something and we didn't get it back, or the claim doesn't contain the right information. So this type of denial is a large volume this type of unprocessable is a large volume. Something on the claim isn't right. I will tell you that while the reason code is very high, you do need to review the remarks code, okay? Because the remarks code breaks this down further. So I didn't actually ask for all the different remarks codes that go with it because it's just too many. If you don't understand what the remarks code is telling you is missing, you do need to contact customer service because you can't bill it correctly if you don't know what's missing. Here's what you should not do. Ask them for the status of the claim. You already know it's unprocessable. You don't have a problem with that. Here's what you should do. I have a claim. It's unprocessable. I can't get it processed, but I don't understand why it's not processing. Or I don't understand what I'm missing. The reason code is this, the remarks code is this. I still don't get it. That they can help you with. But it's very specific to taking it to the next level. A generalized question will be referred back to the regular systems. The regular systems are things like SNAP, the IVR, where you can simply check claim status. Okay. One of the other top unprocessables relates to railroad Medicare. Now, sorry, I think I skipped a slide. I did. Sorry. One of the other ones relates, or the next one actually relates to the prior authorization process. Now, for those of you that don't know, this is RSNAT, the routine scheduled ambulance transports. So we want to make sure we're getting these. This process is not required, but it is something you can do. What happens is if an ambulance transport is approved based on the physician's certification statement, you will be issued a unique tracking number. That unique tracking number is good for a certain period of time. If you append that unique tracking number to a claim it doesn't apply to, that's what causes this unprocessable. And that's where we start to see it. Also, there are base codes for ground ambulance, because that's one of the criteria that don't need a unique tracking number. So when you go to append it onto there, it doesn't work. So that's why we put the two procedure codes on here, the two base service codes, transport codes, whatever you want to call them. So hopefully that makes a little bit more sense. Again, if you want more information on the routine scheduled non-emergent ambulance transport, RSNAT, take a look at the link on the bottom. It's a lot more information out there. But basically, it's the UTN that you appended doesn't apply to this claim. We can't process it with that on there. Railroad Medicare. We're not able to process anything for railroad Medicare. Now, the patient will be listed as a Medicare recipient. That is correct. It is how they are determined to have Medicare. We process patients who have Social Security given Medicare versus the Railroad Retirement Board given Medicare. We don't process those. So if you haven't determined that they're Railroad Retirement Board and they are, then you'll need to send that to Palmetto GBA, Government Benefits Administrator. Okay. So please make sure you are aware of that. Um, Again, it just means that you went to the wrong claims processor. We are both fee-for-service Medicare claims processors. We both are Medicare administrative contractors. It's just who made them eligible. If it's Social Security and they're in our jurisdictions, Jurisdiction 5, Iowa, Kansas, Missouri, Nebraska, or Jurisdiction 8, Indiana, Michigan, then that's us. If they're in the exact same states, then that's Railroad Medicare and not us. So what you got to do is check the patient eligibility, figure out whether or not they actually have Railroad Medicare, all of those different types of items. There is also times when we simply don't get the primary payer information we need. So we look it up, the patient has primary payer information, you check the system, but guess what the claim doesn't have? The completed fields. So they may say, hey, we've got a little bit, or we know this is that, or whatever the situation is. Great. But we still have to have all of the valid information. Now, if it's an unpaid claim and they didn't make a payment, you also need to indicate in the narrative field why it wasn't paid. And that's one thing that will hit you pretty hard here. All right. Oops. Missing or invalid modifier. Again, one of the modifiers on there, the origin destination modifier isn't working. You didn't give an ABN modifier, something like that. Something's not right. It's not a valid modifier. We actually had an ambulance claim come in with a modifier 25. And we were like, what? Because that's an evaluation and management modifier for an office visit or for like a hospital visit. It's definitely not applicable to an ambulance claim. Okay. Also, Medicare WPS does not accept modifier 76 on ambulance claims. Instead, we say, yes, we understand you need a duplicate service. We want you to file an appeal to show us that they are duplicates. Okay? So we want to make that as clear as possible. The next item, oops, is things that are straight out denied or not part of the Medicare. But this is MCS. So remember, we already went through FISS. Now we're working on MCS denials. The first one is actually commonly done because of revalidation or other issues, and it's that the provider is not eligible. This means the ambulance supplier isn't eligible for payment for whatever reason. Now, again, it's usually something related to the provider enrollment file that needs to be updated. Maybe they didn't do their revalidation. Maybe they don't have a current license on file with us. It doesn't mean you don't have a current license. It just means it's not here. Things like that will cause this type of a denial. Okay. Also, things like it is a wheelchair van. Well, we're going to deny that because you're not even eligible to enroll in Medicare. So hopefully that makes sense to people when we look at this. These can come back with contractual obligation or a patient responsibility, PR, patient responsibility, CO, contractual obligation. It depends on what is wrong in the provider enrollment file. So really just what's going on there will drive that one out. Okay. All right, Medicare not covered service. This is where you actually told us you billed it, it's not covered or it's never covered. Now, why do we say you billed it this? Because remember I said EMTs can't diagnose. So therefore, you have to tell us that it's not covered because the transport codes are the same. Maybe it's a BLS transport, except there was no valid reason for that BLS transport. That is a not covered service, and that's with a GY. Could also be with the GX. It just depends on if they gave the advanced beneficiary notice of non-coverage. Okay. And again, this is a large volume. Is this one always wrong? The answer is no. And I know someone commented or asked a question that says bill the patient. For Medicare, that's what we're going to assign these as patient liability. That doesn't mean that if they have Medicaid, you don't bill Medicaid, or if they have a supplemental, you don't bill them. They'll just be signed patient responsibility, and then you do have to follow the remainder of the billing guidelines that go with it. So hopefully that all makes sense. Sometimes these are actually billed at your request, right? They're billed because what you're looking for is to get that denial. Say it's not covered by Medicare, go on, and maybe they're going to have a secondary pay it. So lots going on with that one. Not always wrong, and I want to make that as clear as possible. It's not always wrong. This one is one of the most misunderstood denials. So the patient has a Medicare Advantage plan. This means they do have Medicare. However, the patient has elected to have a private insurance company pay their Medicare benefits, both Part A and B, and part of that is to pay for these hospital transports. It's Medicare Advantage. This information is available on the eligibility systems that you have access to, so please make sure you're checking that. The Medicare Advantage plan will be listed and you do have to bill them. They can have other billing requirements than we do as traditional fee-for-service Medicare, and that's because each Medicare Advantage plan has a unique billing system and way of processing the claims. So sometimes you may have to do something for them, you may have to do something for us. Someone said, well, why would I have to file a corrected claim? And this is a great question. Now, a corrected claim in this case means file a new claim. And why would you have to do that? You may have to do that because the system updated to show that they're no longer eligible. So you got a denial for it. Now the Advantage plan said, oh, wait, they're not eligible today. And guess what? Now you have to refile a claim because it's denied. So we want to make sure you're aware of what's going on with that. Okay. I was asked if there's a place where you can contact CMS about a plan. That's what the MA plan directory is on the bottom of the slide. I'm not sure what kind of help you were looking for. So I wasn't really sure where to go with the question other than that's where you'll find a list of the plans. And then each plan has a certain regional office with control, and you must follow that regional office to get to there. Following the regional office means using the contact for that regional office, which is available on the CMS website. So I, could you help me get a little bit more information if y'all wouldn't mind? Put some more information in the chat. I wasn't entirely sure what you wanted from there. Okay. So that's what we want to talk about. One of the other questions that came in related to Medicare Advantage plans is how do you get it paid when the patient elects hospice? So if the patient elects hospice, yes, you will bill traditional fee-for-service Medicare. For an ambulance claim, you must bill the GW modifier to say, hey, yeah, I understand they have a Medicare Advantage, but it's got a hospice diagnosis. I'm putting the GW on because it's not related to the hospice condition today. If you don't do all of those steps, it's going to deny for one, Medicare Advantage, or two, bill the hospice. So a lot going on with that, and is that related to the systems. Um, I think the person I was asking was also asking something about why Medicare Advantage doesn't pay for hospice. Medicare Advantage doesn't pay for hospice because it's an option for them, and they can elect to have it all sent to Medicare traditional fee for service. The reason for that is the way the law was written, it's a separate section of the Social Security Act that puts MA plans in place and allows for that. It's not your regular Medicare area. So, but it also does allow additional benefits. So they may pay for certain things under hospice that we would not. And I'm not sure exactly what you wanted there. So hopefully I got what you needed. The next one is a duplicate claim. And this just means if either the claim or the line itself is already in our system. Now, as I talked about with this one, some of this is based in a modifier, right? And it's not an exact match modifier. It can be I went from residence to hospital twice in one day, but it could also be I went from residence to hospital and then hospital to hospital. So almost match. It's the same patient, the same data service. What we're looking for and why do we duplicate these? We want you to file an appeal to show us that they were separate times and are medically necessary separate transports. So hopefully that makes sense for why these duplicates happen. And again, you can see the data there. It's a higher volume than what we would like to see. The last denial I would really like to speak on, you've already heard a lot about it, and that's just the primary insurance. Now, some people say, well, I can't gather that. I don't know how to get that. The patient isn't able to give me that. Okay, but if you have the patient number, why aren't you checking eligibility to make sure that that information is available to you? So why aren't you using our CMS Secure Net Access portal on our website to check eligibility? Okay, I'm not really sure that's going there, so that's the question for you. And we'll talk more about that in just a few moments. All right. I do want to provide you guys with just some really basic resources. As you can see, I built a bunch of them into the slides, but I do want to talk just a little bit about playlists because on YouTube, we offer playlists, and playlists are available to you to help you through all the different education, which would incorporate this one that we've recorded and a variety of other things. And because ambulance suppliers bill everything differently than a lot of other providers and they use modifiers differently, we want to make sure that you have your own playlist and you're available to them. So let's jump to the website. We'll show you a couple of resources, then we'll move to question and answers. All right, so start with WPSGHA.com. I talked about SNAP or the Secure Net Access Portal. It is right here. If you want to know how to check for eligibility, come to the portal user manual. Now right here is this dark blue box. It's got a user ID. These are typable passwords. And then these are typable fields and you will have to enter a password. On the portal user manual, it's going to tell you, how to register all of that stuff. There's a couple of different sections I like to point out to people. Patients, eligibility check, right here. If you go into that, it will define for you where the information comes from, all of that type of information, and I'm just going to scroll down. If you enter all of the fields, you'll get two different fields coming from CMS. One says eligibility information and one says supplemental information. This is who pays after Medicare. This is the basic Medicare eligibility part. And then you can see on the very next area of that, you've got different sections. One of those happens to be Medicare secondary payer. Now on this particular patient, it is grayed out, and that's just because they don't have that information. but it is in the second row, second item, and you'll see MSP, Medicare Secondary Payer. That field is used to indicate who is primary. Next to that, the third item is the Medicare Advantage MA plans, and you can also take a look at any of that. Hospice is fourth, so you can look at a variety of pieces of information according to what CMS has on file. Um, on the WPS YouTube channel, which we did talk about, and I gave you direct links to these, I do want to encourage you to come out and check out our playlists and then type in ambulance right here. What it will do is sort, if I know how to type ambulance, what it will do is actually sort. So you're going to get ambulance documentation requirements, all these different things, but you see the third one down is ambulance suppliers. This is a playlist that will link you to all of our videos. You can, oops, let me pause this. You can see them all listed here. So we do have quite a bit going on with ambulance. So those are just a couple of resources that I found super helpful when we were looking at denials and what's going on with it. With that, I'm going to move to the next slide, which is actually the question and answer slide. What I'm going to do is I'll run through some pre-submitted questions, and then if we have time, we'll hit the chat questions. Okay. First pre-submitted question: when Medicare is primary for the Medicare Secondary Payer Program and the 30-month coordination period, ESRD eligibility. And the answer to that is when a patient becomes eligible for Medicare due to end-stage renal disease, the first 30 months that they are eligible, the other insurance is primary. Once that 30 months passes, then Medicare becomes eligibility. This is all determined by the Social Security Administration. So our system just simply feeds back from whatever the Social Security is giving us. Next question: what modifier to use when transporting a patient from an imaging center that is owned by a main hospital but is off campus? Um, I do want to let you know that it is an H, and it is an H because it is a hospital. It's not a completely freestanding diagnostic therapeutic center, which yes, they can be there, but because this is a hospital off-campus department, it would still be an H. Do denials affect the picking of ambulance services for an audit? And the answer is absolutely. When we look at audits and when we look at especially like the targeted probe and educate services, which we do have two going on right now, the denials are what factor into it. What's going on with your claims and how much are we getting? So are you an anomaly? Are you outside the norm? Um, when your crew, the next question is how to reduce denials based on how crews chart. The first thing you want to do is read through the documentation. Go to the narrative. Yes, the checkboxes and the items that they did are great, but they don't give us the information about why that EMT's medical skills were needed at any level. Now, CMS does say an EMT is a basic, intermediate, or paramedic. It doesn't matter to us how your law defines it. It does matter in terms of payable services, but if your law says an EMT is not a paramedic, that's okay. CMS does include it in that. So when I say EMT, I'm including any level. So their narrative is what makes that description so much more payable. Hopefully that makes sense. Um, Billing modifiers that are required. Well, of course, we always require the origin and destination modifier. We may require a GY or a GX if it's not medically necessary, or a GA should it be provided at a higher level of care. That comes in for like air when ground would have been safe. It's medically necessary to go. We're not saying that. We're saying, hey, it wasn't medically necessary to go by air. They could have safely gone by ground. Also, the GW for non-hospice related ambulance transports when they're in a hospice stay. So those are some different billing modifiers that may be required. I want to remind everyone that there are two modifiers for facilities that tell us are they wholly owned and operated or not. So you want to make sure you're aware of those. That's going to be right back here. If you're looking for that information, come to this Medicare Claims Processing Manual, and here you're going to see same section that I just looked up for the origin destination modifiers. Just right below it, you'll see the Q and the M. QM and QN modifiers. Just make sure you're using those appropriate, but those are only available for the UB04 and the 837I, the only time they're required. Right. Next question. Um, let's see. How to avoid denials for two trips in the same day, and there's a variety of factors that play into this. Again, as I said, our system doesn't avoid the denials, it actually does deny it, whether it's an exact match or a similar match. Okay, so we know it denies, you got to do an appeal. All right, when what to do when a claim is denied when all the info you've entered is true and correct. I would want to reduce denials to learn what it looks like. First, there are times when a claim should be denied. It's not medically necessary. So all the information you entered was perfectly correct, just not medically necessary. That would stand as a denial. On the other hand, you would have to do an appeal to look at that. Third, you may say, I got to bill the patient, or I have to bill, and I'll make this up, a skilled nursing facility or a hospital. So those are also types of denials. So you entered everything correctly, only you have to bill someone else, right? That's also a possibility. So, um, we've asked a little bit about modifier usage, and I think I've covered all of them, but I will show you again, just a second, some information on modifier uses. What exactly is billable besides a base rate and mileage? Medicare will tell you you can bill any ambulance code. It's whether or not we're going to pay it, whether or not we're going to consider it. We will only consider your base rate and mileage, though you could bill us for any ambulance code, such as a treat no transport. You could then also bill any of the supply codes that you need to bill that go with that treat no transport. We just won't pay them. You want to put a GY on and say, yeah, this is not covered by Medicare. We know that, right? That's what you want to do there. Um, how do we ensure patients are not misled when there's a medically necessity denial? Often they call and tell us their trip needs to be recorded. What's correct? First, the hardest part about answering this question is that a patient doesn't contact WPS. They contact 1-800 Medicare. What they say to 1-800 Medicare can be very different and interpreted very differently. So what you need to do is say, oh, you don't agree with how the claim processed? It's not about us rebilling it. At this point, we're not required, we can't rebill it. Medicare doesn't allow it. We need you to file an appeal. And that's where they have to go. Um, One of the next statements was just very simply clean claims and treat no transports. So clean claims are any claim that doesn't hit an edit or an audit that you get a request for. Now it can hit edits and audits within our system. That's perfectly fine. It just means we don't send an ADR out. So that's all a clean claim is. We do have 30 days to process those, but the first available date of payment is either 14 or 28 days, and it just depends on how they were built. You can bill treat no transports. I just talked about that, but please include the GY or the GX. This is what needs to be done, and by billing them, it does allow the patient appeal rights. All right. Next, are all supplies included in the ambulance run charge? The base rate does include all supplies. That's a part of the bundling of the ambulance fee schedule. Who should decide if a transport is a benefit or not? Great question. First, the EMT should start with their documentation and their assessment because they're the ones that are physically there to look at it. Don't use a dispatch code. Don't use a physician certification statement alone. You want the EMT to assess the person. Now, if they assess it to be not medically necessary, if they write it's not medically necessary, that's all fine. If they assess the things to be medically necessary, that's great. Then a coder can look at it and take it from there. Okay. Um, so again, it's the EMT, but the coder may have to interpret what the EMT is assessing in the written narrative and the information available. So yes, it's two different people. I get that in some cases. All right. I know that we're over, so you guys are welcome to disconnect. I'm going to have Leanne throw that chat link, or I'm sorry, the survey link down in the chat. Other thing though, I would like you guys just to hang on for a couple of seconds, and I want to ask Leanne if there's any questions I can answer before I let you go.
Tom, there are three unanswered questions if you'd like to take those.
Okay.
The first one is if we have to move the patient via ambulance after second day of inpatient stay, is that not covered?
Can you tell, and the basic answer for that is a couple of things. One, can you tell me when you say you have to move the patient, are they moving to a higher level of care so they're going to be discharged from the first facility and move to the second? If it is that case, yes, that can be covered. You do have to document why the higher level of care is needed. So let's say that you discovered the patient has more of a cardio issue than you thought, therefore they need a cardiac lab. I'm totally, throwing out kind of higher level scenario out there. So yeah, yes, it's covered, but you really have to document why, and the patient has to be discharged. Now, the system doesn't say they're discharged at 10 or 11 or whatever. So sometimes you actually have to file an appeal simply to say, hey, they were discharged at this time because the system doesn't have a time in it. So it's a little weird with that one. Hopefully I answered the question. Leanne, anything else?
Tom, this next one may need to be taken back, but I'm going to throw it out there. Does WPS have any plans to add the actual policy number information to the MA information in the MA section?
WPS can only give you the information available from CMS in the 270-271 HIPAA standard transaction. It's called HIPAA eligibility transaction. So until CMS adds that into that transaction, we cannot give it to you. So at this point, no, we don't because CMS doesn't have it available to us. Next question.
Last question. In regards to the question about ESRD, I actually had Blue Cross Blue Shield plan tell me they did not follow the Medicare MSP ESRD 30 months. It's more of a statement.
Yep, and that is correct. They don't have to. If they're a Medicare Advantage plan and they're the replacement plan, they do not need to follow the 30-month coordination period. That's a different set, and you have to contact them. Again, if you're having issues with that, we do recommend going back to that slide, checking out the CMS contacted regional office. And as Leanne said, that was our last question, so I'm going to go ahead and go back to the slide. I'm just going to move on for y'all. So again, take the survey. It's literally 4 or 5 questions. Provide us some basic information. Help us out. CMS does look at these surveys. They really want to see how we're doing. All right. There's a chat link, which Leanne has put in there, betting a few different times. There is an auto pop, which looks like the external site picture. It's the upper right picture here, the little triangle. That will automatically pop for you. You can click the continue button. It'll take you to the survey. You don't have to do anything. There is the opportunity to take the survey from the email, which you're going to get in just a few moments, and I'll talk about that. And last, there is an opportunity to take the survey in any Encore presentation, and that looks like that little bottom picture of the online survey. When you see that picture, if you select it, it will take you out to the survey. Couple of just really quick wrap up things. I'm going to send you a thank you email in just a few moments. Now, I should say I'm not doing it. The system does this. This email does contain a certificate of achievement with contact hours. Those are used for continuing education units. They don't have anything to do with us. If you dialed in and you cannot get that because you didn't give us your email, what I need you to do is follow the directions for the next 7 days and get us an email. Leanne, put the directions in the chat. I'm sure by now they're already there. What you need to do is email us. When you email us at wps.gha.education@wpsic.com, in the subject line, indicate ambulance claims webinar, ambulance webinar, something to do with ambulance. And then in the body, give me a 10-digit phone number and who you are. I need that 10-digit phone number to verify that you were on the system. And then that lets me send you an actual email, a certificate, and otherwise you'll automatically get one. Okay. Again, as I said, you have 7 days to send any follow-up questions. Feel free to do that. It's the same email address I just gave. So on behalf of myself, Leanne, and all of Provider Outreach and Education, thanks for joining me. I apologize that I did go a little bit long, but hopefully you got some much needed information. You may now disconnect.